Hello, everyone. My name is Andrew Spiegel. I am the CEO of the Global Colon Cancer Association. And I first want to thank all of you for attending today. And I hope that you found these sessions as valuable as I did. And the second thing I want to do is thank our superstar, Candace Henley. I've known Candace for almost 2 decades now, ever since she got unfortunately involved in the colorectal cancer advocacy space. And I've met hundreds of advocates in the more than 2 decades I've been involved in the movement. And some come and go, some get involved and some don't, but Candace Henley has been involved since she was diagnosed, and she is a superstar in the colorectal cancer patient advocacy space. And I want to thank you for all of the work that you've done in putting this conference together, in getting us top-notch speakers, in getting a fantastic agenda locked down, and really in providing the community with this super valuable information that you really provided everybody today. I thought it would be important for us to talk about you for a moment. You not only are a director of health equity and partnerships, but you, so to say, have skin in the game. You're a
Yes.
colorectal cancer survivor.
Yes.
Why don't you tell everybody just a little bit about your story,
Sure.
of how you got involved with this and why you got involved, and what colorectal cancer did to you when you were diagnosed?
Definitely. Health disparities is not new to me. And that's why this conference was so near and dear and very important for us to do, was because of my own journey. And I was 35 when I was diagnosed, but it took 6 months for me to even to find out that I even had colon cancer. But it took 6 months and a hysterectomy because I was so young. They didn't expect that colon cancer was the issue for me. So I went to the emergency room 3 different times, and each time they sent me home. So by the time and every time I would present with symptoms, it was always assumed that it was something else. And after they couldn't take anything else, that's when they finally decided that, okay, we need to test and find out why you're having this bleeding. And so they found out that I had colorectal cancer through an FOBT kit and then a colonoscopy. And the colonoscopy revealed that I had a grapefruit-sized tumor on the right side of my colon. And I never left the hospital. And that's where my story with disparities began, because no one ever asked me if there was anything going on at home. No one ever said, do you need to take care of anything? So here I am, 35 years old, a mom of 5 children, and never left the hospital. Spent 10 days in the hospital, and life still kept going.
Your 5 children.
5 children,
Right.
Bills, everything. It still kept going. And they removed my entire large intestine. And I remember the surgeon said, I fully expected you to be able to go back to life as normal. And I was like, if you just removed my large intestine, one of the major organs, how is life normal? But I thought that was normal. And it wasn't until I met other survivors that I realized that what I experienced was not normal. It was disparities. I didn't have patient navigation. I had no resources. I had no social, social services. No one checked on me once I got home outside of the surgery suite, just making sure, that my wounds were healing. But outside of that, no one asked, do you need anything? Are you okay? And that led me to not being able to return to my job as a bus operator. So I had to leave my job. I didn't qualify for any of the services, in the city because I was a homeowner. So I was penalized for being a homeowner. So there were no services to help you if you owned a home. And disability through my employer was only $184.
To raise 5 children.
Yeah. So thinking about all of that, and then even applying, and at that time in 2003, colorectal cancer wasn't on the list of cancers for Social Security disability. So I was denied that. So I wound up homeless with my daughters because there were no services available. There was no information, no access, no resources. But it wasn't, but everywhere else, other people had that. I did not. I was never offered it. So that's why this is important. And when I recovered, when I got on my feet, I was determined that I needed to make something out of this and not just have loss be the end of the story for my daughters. And although I felt defeated, I felt hopeless, I felt like no one saw me, I felt invisible. And I felt like, was I being punished? You know, was I not a good citizen? Did I do something? Because I was like, why am I 35 with this disease? And there was no information. And I lost friends because they didn't know what colon cancer was. They thought colon cancer was associated with HIV.
Yep.
So we have education, resources, information, and a lack thereof that still 20 years later still exists.
Yeah. Oh, it still exists for sure. So, Candace, how did we get here? How did we get here to begin with?
That is a very important question. And it's very significant because a lot of people don't know this. And so our healthcare system was never designed to treat minorities in the first place. It was always built on discrimination. So when we talk about having equitable access, how do you have equitable access in a system that was on its face, never designed to treat the minority population?
Can you explain why?
Absolutely.
What do you mean by that?
So and when I say that, I mean from the state of 1619, from when slaves became part of America, as we know, the transatlantic slave trade. The only way that African Americans were allowed access was if it benefited the slave owners. So that meant if you had a slave that was ill, you had someone treat them. So there was only benefit unless there was no benefit for us being a part of it. Moving into the 19th and 20th century, you still had segregation in hospitals. And it wasn't until actually the Civil War until we started having access to going to the hospitals, but it was still segregated. When we move into the 1960s, the only reason why our healthcare system became segregated was because the federal government threatened the hospital systems and said that if you do not segregate, we will not fund you. So that was the onset of Medicare. So the hospital system, the medical system was forced to desegregate in order to receive federal funding. So those disparities that we talk about from the onset of slavery until present day. So now that we're talking about present day, we're talking about Jim Crow laws that were put in place, redlining, insufficient funding in communities of color. All of these things were designed. So when you have intentionally designed ways to keep people from having access, now the issue is now starting to affect everyone. So our healthcare system was so built on red tape that now the red tape is now impacting everyone that is a part of the healthcare system. So how do you undo the red tape?
Right.
You can't. And we keep saying, we're going to fight for health equity. We're going to fight for health equity. Where? Where is there room for equity? It was never designed for that. So we need a whole new healthcare system. This is what we're working in. It's never going to be health equitable. Even when you have doctors now, we still have low representation. We are still saying we need representation. In 2023, we're still talking about funding. We're still talking about access. We're still looking at the difference in funding for hospital systems that are in white communities. 71%, I think it's 72% of funding goes to those hospitals.
Still. So these conversations are difficult to have
Yes.
with policymakers, with leaders. How do you have those difficult conversations?
Oh, when we're talking about having difficult conversation with global leaders, we have to think that it's different in the US versus abroad. And we know that here in the US, we have freedom of speech, right? We have the rights, there are certain rights that we have. But when we think about our neighbors and our friends, in low to middle income countries, that's not always so. And so although we want to say you should go and talk to your, your government and say this, we don't want to push people in situations where their lives are in jeopardy because they are looking at what we're doing here and they're going. So my suggestion and what I think should happen is when we're talking about leaders is that we're saying, bring information respectfully and saying, here is the state of colorectal cancer. Here's the state of what this looks like in our country. And I always like to say your country, your community, your hospital, your church is only as healthy as the people in it. So if you have a country full of sick people, your community is sick, your country is sick. Bring data, show information as to why this is important, why the state of emergency is happening right now. And then also bring information as to how can we talk about collaboration, bring information about what's happening abroad, the advances in technology, advances in medicine, and talk about how that can help reduce disparities and the importance of collaboration.
Mm-hmm. Yeah. When you came to us to work as our director of health equity, we had difficult conversations. We had conversations about our own organization and our own programs.
Yeah.
And we took an audit of our programs and we thought, with your help, we wanted to become more equitable. Can you sort of describe some of the global programs that you've helped create for us that start to address some of the health equity disparities?
Definitely. We'll talk about
starting with blue
hat bow tie, right?
Blue hat bow tie. Tell everybody about blue hat bow tie.
Absolutely. There is blue hat bow tie was created out of me wanting to find ways to talk about colon cancer that was non-threatening, because no one wants to talk about colon cancer. They'll talk about breast cancer, but no one wants to talk about colon cancer because of the location. And whenever we brought it up, it was like, oh, no, I don't want to talk about it. But we needed to find a way to educate people, about what colon cancer is, how you get it, information so that when to get screened, because I never knew, I didn't know. And then the fact that people that I knew associated with HIV, I was like, wait a minute, something's happening here. And so just out of sheer, how do we have this conversation? I saw a documentary on the Red Hat Society, and I was like, great, those hats look amazing. But what would that look like with blue hats? And I talked to my family members and friends and said, you know what, in March, can we just come to church, with blue hats and bow ties? Because what we also recognize is that when people go to church, that's where they get their healing, right? Access. It's a trusted source of information. It's a trusted resource. And so people go not only for their spiritual healing, but also for mental healing. And so it went over so well. And we were like, oh my goodness, it turned into such a fashion statement. Blue hats, blue bow ties, blue suits, blue shoes. But we recognized that what people were doing, it was education through participation. So what that means is people are more inclined to remember the information they received and share the information they received when they participate. So the fact that they were wearing blue, and if they shared that information or they saw pictures, they're like, what was going on? Well, my church, it's March, it's Colon Cancer Awareness Month. That's the color of blue, and my church participates. And so bringing that here with Global CCA was such a fantastic opportunity to take this not only here in the US, but on a global scale, because it was an event that didn't require much. It just asked people to participate. Mm-hmm. And it, but in a way where they would be proud to, but it was also non-threatening, where they can talk about it, and they became accidental advocates. So when people see them, why are you in those blue hats? Why are you having those bow ties? It's colon cancer awareness. We're raising awareness of colorectal cancer. The color colorectal cancer is blue. And it gives people an opportunity to talk about statistics if they know it, to talk about who's more impacted by it, and to encourage people to get screened and let them know when it's time for them to get screened. So being able to see this on a global scale, it was a no-brainer, right? It was a no-brainer. It was like, this is something that we can do that wouldn't financially harm people to participate.
Right. And you helped develop the whole program where people can do it in their communities.
Yes, the toolkit.
It doesn't have to be a church event.
No,
it can be.
It can be anytime. It can be any time of the year. And that was one of the things too. We wanted to be intentional because we know that religion is special. Yep. It is personal. But we didn't want people to feel like we were pushing, religion on them. But we wanted them to be like, this is free to do whenever you want to do it. And so that's why we changed the name to Blue Hat Bow Tie for colorectal cancer awareness, because we wanted to make sure that we can make a full impact on anyone wherever they are, no matter what religion you are, no matter what racial or ethnicity you are. This was for all, for anyone, and it was all inclusive. And that's what we wanted. We wanted to make sure that everyone knew that this was something that they could do in their community.
And it was a smashing success our first year, and we're looking forward to collaborating again for the next Blue Hat Bow Tie event. Absolutely. Coming up March. It'll be here in no time. How else have you brought health equity to the GCCA?
Well, I mean, the grants programs, that is amazing, because I think what we're doing is we're talking about ground level interventions, and that is impacting how we see our grantees, right? When we're looking at grants, we were, and I don't know if you remember the conversation we had. We were very particular because we wanted to make sure that we were making a maximum impact, not just here in the U.S., but who else can we help? We wanted the grants to go to low to middle income countries, but it was not limited to that. But that's how we were showing our commitment to make a global impact, to reduce disparities and the mortality rate for colorectal cancer by having these grants. And then we recognize we're not in this area. We're not located there. So we only know what we know from what we see in data, but for the lived experience, they are the boots on the ground. Those are the professionals. The people that see this on a day-to-day basis, they see the disparities, they see the need and the experience. So those are the people that we wanted to talk to. Those are the people that we want to give grants to. And we got some amazing grant applications. And I think we funded all 10, right? The impact is going to be amazing, from paying for colorectal cancer screenings to having events to raise awareness, to doing research and information on clinical trials, education and awareness, and a FIT program. So we got some amazing applications that's going to do some amazing work. But we also were very intentional because we want to make sure that the work was going to be able to continue. So after this grant program, how can you sustain the work that you're doing? So that was what we wanted to make sure, that the work was sustainable.
Mm-hmm. Yeah. So in talking more about health equity, we're really talking a lot about the lack of access around the world. Some of the presentations we've heard today were startling in terms of the lack of access and the lack of ability for people to get screened or to get tested or to get access to treatments. We saw the incident rates that are growing around the world for colorectal cancer. We know that it's soon going to be the leading cause of cancer death around the world. So we were working on prevention strategies to help educate policymakers about this onslaught that's coming. One of the things that we've always been really bothered by is the whole palliative care discussion. You did had a great speaker today on palliative care, and you asked some great questions. Colon cancer is directly affected with palliative care. We know that people, even getting screenings, getting colonoscopies, they don't have access to anesthesia in a large part of the world, or any pain medicines. People that have colon cancer. they could have a tremendous amount of pain.
Yes.
And they don't have access to any pain medicines.
Mm-hmm.
There's no equitable access to even the most simple thing. Forget about the cures and the immunotherapies and the biologic medicines.
Yeah.
They don't even have access to the most basic pain medicines.
Yeah.
What are we going to do about this?
We have to advocate. We have to advocate. We have to collaborate. I think Dr. Hasty has an amazing, her presentation and talking about bringing that to the forefront was mind blowing. Let's start with that, because I didn't even realize that this was happening. And so bringing that to the forefront, collaborating, working with the WHO, working with the health ministries in these countries and asking how, what precludes you from having medicines in your country? I mean, I think we need to understand. I think we still have a lot of work to do in understanding what the challenges are. But what are the challenges? Is it financing? But we also know that some of it is the idea that narcotics creates drug addicts. So we have that bias, right?
Mm-hmm.
And then we have in some cases where doctors don't believe in pain medicine. I just cannot for the life of me understand someone seeing another person, another human being suffer through the pain of cancer. It's painful. It is inhumane, and it is not dignified. And I think when you don't have that personal experience, that personal knowledge, you really don't understand, or that compassion is not there. And it's almost kind of like how our policymakers are, right? Until it impacts you, you really don't get it. And it's like your energy is not there until there's a loved one or someone or yourself is impacted by it. And you go, oh my God, why didn't anybody tell me about this? It's like when you buy a car, you don't see that car until you buy it. And then suddenly you see all the cars on the road. That is what it's like for people. How can you think about another person suffering and not go, oh my God, this is wrong? So that dignity aspect is important.
Mm-hmm.
And, and I keep saying that because I felt like no one saw my humanity, and I didn't have the dignity to say, Candace, is there anything that you need? No one gave me the opportunity. They didn't give me that. And no one asked me those questions. And I'm always a fan of saying, when we talk to patients, ask them a dignity question. And that dignity question is there anything that may have changed or anything that may prevent you from making your next appointment, from from participating in your clinical trials or whatever it is? And what that does is it gives the patient the opportunity to say, well, I have issues with transportation. I have to take care of my children. It's a doorway of asking a question if there's a need without making the patient feel embarrassed or talked about. Because, sometimes we feel like, okay, I can't tell them that I don't have money. And there's patients that have walked to appointments because they didn't have money. So in hindsight, what I'm saying is, I think that we have to do a better job in talking about the needs of the patient and making patients partners. And policy. We have to advocate for policies.
So you were talking earlier about 3 pathways.
Yes.
Can you explain those?
Yes, the 3 pathways to patient-centered care. And that is agency, dignity, and representation. And so when we don't have those, it's like, where is my ability to make decisions? Where is my ability to be seen? And my representation. And when we say representation, that means people in the healthcare industry that look like me, that make me feel comfortable and secure that the decisions that are happening and that the things that are happening to me, you understand. Because we recognize that, we all have different backgrounds, but you may not understand my fear. My fear about clinical trials is historic because we know about the Tuskegee experiment, right? We know that clinical trials and experiments have been done on minorities. So my fear comes from a place of history. But if you don't know that, if you don't know that historic context, and if you don't look like me, you don't understand. And you think that I'm being a difficult patient. You think that I'm overreacting or being a trauma queen without realizing that, wait a minute, this is a legitimate fear. So representation matters on a lot of fronts, right? With Black men, we know that Black men have issues, with perceived masculinity in terms of getting a colonoscopy. Well, we know that maybe some doctors may not recognize that. They may not understand that. But another doctor, another Black male doctor would understand that and would be able to have that conversation and say, hey, it's the language, it's the conversation. Right. So that's why representation matters. And we go back to dignity again.
Well, let's stick with representation for 1 minute, because
absolutely.
People in the U.S. understand Tuskegee and things like that, but our global audience may not have a reference to what can you explain a little bit more? Why would you have some distrust for your healthcare provider, your system? Other countries may not understand, or they may have the same distrust for other reasons.
Yes. So medical mistrust, the Tuskegee was a syphilis study that it was a 30-year study that was done. And I think it started in 1942. Don't hold me to it, but you can look it up. It's the Tuskegee syphilis study. But it was done on Black men. And they were told that they were getting medication for syphilis, which they did not. So over this time frame, the doctors, the scientists were monitoring the difference in how syphilis was growing and manifesting in different ways. So these men, thinking that they were getting treatment, they were getting placebos. They were getting water, not water
sugar
pills,
pills.
Sugar pills.
Yeah.
So they weren't even getting treatment. So this study went on for 30 years until it was exposed by a reporter. So when we look at, and then Henrietta Lacks is another story, the HeLa cells. So the cells that, that were used for, the creation of the COVID, the COVID vaccine, thank you, that was used to create the COVID vaccine, they were taken without her permission in the 1950s. She had cervical cancer, and they found that her cells replicated. So they never got, she didn't know, her family didn't know. And it took all of this time until just, I think maybe 2 months ago, that her family finally got restitution for for her cells being taken and used over and over again, helping to cure diseases throughout the United States and abroad. So when you see that type of action happening, yes, there's distrust, because now I feel like I'm a guinea pig. Because if you've done this, what will you do to me? Mm-hmm. And so most people don't know that now, since then, there have been IRBs have been put in place for the research, human research subjects. So most people don't know we have guardrails now. So those guardrails are in place so that humans cannot be used as research subjects.
At least in the U.S.
Yes, at least in the U.S. Exactly. Yeah. So this is important information to have, and of course we know that it's not just here in the U.S. We know that eugenics happened, right? So we have in this world a history of atrocities that have happened, not only just here in the U.S. but abroad.
Mm-hmm. Okay, so that sort of helps explain the agency piece,
yes.
Right?
Yes.
The other two pieces were representation and equality.
Yes, equality and dignity, yes.
So representation, what do you mean by that?
Just meaning being in spaces and places where people exist that look like me.
Like a doctor,
like
as
a doctor.
You explained,
yes.
A Black male that may have
absolutely
hesitations about getting colonoscopy for cultural issues,
yes,
would best be addressed by a doctor that
absolutely
looks like him,
absolutely,
that he could talk to.
Absolutely.
And that's a big problem around the world, that in underserved and underrepresented and under-resourced communities, mm-hmm. there is a lack of healthcare providers of color.
Yes.
And still to this day, this is true.
Yes.
Yeah.
Yes. We're still saying, hey, we need more people in medical school that represent communities of color. And it's a struggle. However, we also are finding that, there's an issue, with going, but that's a whole nother issue. We won't go into that because that's a whole nother topic. But we know that, as years have passed in the last 25 years, there are less and less minorities participating in medical school because they can't afford it.
So you say the whole healthcare system's broken.
Yeah.
It can't be fixed. We need systemic change.
Absolutely.
From the beginning?
From the beginning. Everything from the root up. Because we still, and here's another thing too. I always ask institutions, when was the last time you checked the policies of your healthcare system, the policies of your hospitals? If your hospital has been in place since before the civil rights movement, you probably have some issues and some policies that are outdated. So no one thinks about that, right? So when you're in the hospital and let's just say you come across an issue and you're like, hey, well, I tried to get A, B, C, and D, and the nurse said, or the doctor said it was against your policy. That's an outdated policy, but they hold to that policy because it is on the books. So we also need to have this discussion about, are you reviewing your policies in your hospitals?
Is there an example that comes to mind about how those policies were disparate in their treatment of people?
Well, I mean, we talk about segregation, right? And
Yeah.
so we talk about disparities, and I won't say that. I can say that it contributes to biases, and the bias is when we have like minorities, have more pain tolerance, or the thought process that, well, you know what, I don't believe in pain medicines, and African American men or Black men, minority men, have less opportunities to receive narcotics for pain than anyone else.
Because there's a presumption.
There's a presumption of drug abuse.
Right off the bat.
Right off the bat.
Mm-hmm.
So are these policy issues, or are these biases, or a combination of the both? We won't know. Why? Because when was the last time someone looked at their policies in the institutions? So we want to make sure that if we're talking about health equity, that we're not only just looking at the healthcare system itself, but we are looking into the institutions, because the institutions also have to change.
And when we talk about these biases and they're not always so obvious.
No, they're not. Microaggression.
Right. They're very well hidden sometimes. For example, in clinical trials, you have educated and continue to educate the world, literally, from those who are developing drugs to government to patient advocates on clinical trial, and how clinical trials are naturally biased against minorities.
Yes.
And it's been truly eye-opening, and it's been conversations that we've been having now in Geneva at the World Health Organization and other. It's a true awareness that there's an implicit bias. Can you explain that?
Oh, absolutely. Because, clinical trials, when they create these clinical trials, the researchers, they have a specific subset because they want to have what they call clean studies, right? However, if you have a pre-existing condition or other comorbidities like high blood pressure, diabetes, that automatically, is a non-starter, right? So that kicks you out of the trial. Well, if you're looking to diversify your clinical trials, well, you need to change that criteria, because majority of, 9 times out of 10, well, maybe not that high, but African Americans have the highest rates of diabetes and high blood pressure. So if you have a clinical trial, and let's just say I develop something along the way in this trial, I get kicked out of the trial because I now have diabetes, or I now have high blood pressure, or I'm not selected for the trial because I have diabetes or high blood pressure. So we're saying your inclusion criteria is discriminatory, and your exclusion criteria is discriminatory. And so we're asking, is it a necessity that you discriminate or exclude individuals that have high blood pressure and diabetes? And is it a non-starter? Is it really going to affect your study? Or is this by design and by choice? And so if we're talking about diversifying clinical trials, then we need to go back to the drawing board, and we need to redesign clinical trial participation, what it looks like, and make sure that we are being inclusionary and not just talking about, well, we want to make sure that we have diversity. Well, how can you have diversity when you keep having all of these exclusionary criteria?
Right.
So we have to do better.
And
we have to fight for it.
Yeah. And as you take this to educate people around the
Yes.
world, what has the response been?
Shock.
Yeah.
But some is shock, and others is like, well, yeah, we know that, we understand that, and we know that we have to do better. But it's like, but and that's the thing. It was like, yes, we know that, and we need patient advocates, and we need patient organizations and patient groups to help us work through designs on how to create a clinical trial design. The issue, as Dr. Carlisle stated earlier, is that that's great. But when you have a patient at the table with a doctor that feels like, I know it, you're just a patient, we tend to be looked over, or as he stated, talked over, because the individual who has the education is saying, well, I know better. But those of us that have the lived experience, we're saying, no. But not enough of us are saying, no, you don't. Here's how you need to do this clinical trial. This is how you build an inclusive clinical trial design. This is how you bring in more minority participation, by listening, by doing, the work in community engagement, by asking community members, what is it that you need, or what would it take for you to participate in this trial? Because so often we're not asked.
Well, so when somebody that is running a clinical trial feels, well, we'll just open up the trial in a minority neighborhood.
Right.
That doesn't work.
No.
And why doesn't that work? And what should they do?
Well, because you haven't done the work in educating the community. You haven't done the work in making a relationship, developing a relationship. You haven't done the education. You haven't made the case for having a relationship and saying, here's what's happening. And you didn't ask the community. Did you ask the community if this trial is what they wanted? Because so often, we get this all the time, like, hey, we're coming in to save you. We know that you have this highest rates of such and such and such, but my issue might be mental health. I don't care about cancer. If my mind is not right, what do I care about mental health? So we have to do a better job. The medical community has to do a better job in talking to the community, developing a relationship, and asking, what are your needs? And then also working with the hospitals and the communities that you're looking to go in, and looking at the community health needs assessment report. The community health needs assessment report is a report that hospitals put out every 3 to 5 years. This report talks about the different needs in the community surrounding that hospital and those that participate, those that have visited that hospital. This report says what is important to this community, and you will find that from community to community, the needs are different. So whereas your clinical trial might be about breast cancer, I have colon cancer. We have higher rates of colon cancer in this community. Your trial is not for this community. Mm-hmm. So how about we talk about a clinical trial for this community? Or let's talk about what else we need. But also, when we bring in clinical trials, when clinical trials come into communities of color, the researchers don't take the time to ask, why won't you participate? This is good for you. You should participate. They're not listening. And we're saying, here's the issue. So we have to do a better job with our research community and making and helping them understand that history matters. Cultural competency should be a requirement, not an option. Know the community that you're going into, know who you're talking to, and understand the historical barriers, the personal barriers, the community barriers, and what's important to the community.
When you talk about you and the doctor being at the table and the doctor feeling they know best,
yes,
that to you is in itself a disparity, isn't it?
It is.
That a healthcare provider knows better than you about decisions that are being made for you,
yes,
about you.
Yes.
About you. And I remember one of the examples that you've given in the past and some of your other speeches that I have heard. You talk about maybe not wanting the doctor to make this advice for
Yes.
you or to keep information from you because they're making decisions for you or about you without you.
Without me, yes.
Could you give an example?
Absolutely. My whole entire journey was not my decision. I made not one decision. I did not choose my doctors. I did not choose the surgeon. I did not choose
The type of surgery?
nothing.
No, right.
Nothing. And I felt like, initially I felt like, wow, this is great. They took care of everything, right? But then I was like, wait a minute. I didn't know anything. I didn't know why they chose the surgery. I didn't know why they chose the treatment. I didn't know why this was the best. And I was like, and so this is why I asked the doctors, does the treatment match the life?
What do you mean by that?
My surgery was an emergency surgery, but I questioned, was it really? Because after a while, the issues that I came into the hospital having had kind of calmed down a little bit. But I'm a single mom with 5 children. No one stopped to say, wait a minute, is this treatment best for her life? Can we do something else? Can we do a different surgery? Did they have to cut me open? Could they have done laparoscopy? Does the treatment match the life? Is chemo the best option? Is radiation the best option? Is a full day of radiation the best option? A full day of chemo? Those are things, what I'm saying, does the treatment match life? I have a 4-year-old, I have a set of twins, and I have 2 teenagers. So I got a lot going on, right? So what about those that are taking care of parents, that are taking care of small children, or they have someone in the home that might be disabled? The treatment program may not necessarily match the lives that is happening at home. So we have to think about that when we're prescribing treatment for the patients. Is this best for the lives that they have right now?
And not only that, but you've also talked about where physicians will withhold information or not tell you about a treatment option.
Yes.
And I remember you yelling, don't spend my money. Don't spend my money. Don't tell me how to spend or not spend my money. What do you mean by that?
Well, because so often they're like, well, you know what, this might be more expensive. This treatment, we didn't bring this information to you because their treatment is expensive. It's precision medicine, or it's, it might be out of your price range. And my thing is, let me deal with that. Don't make the decision or don't give me information because you perceive, and so it's perception. You perceive that it's expensive for me without asking me whether or not I can afford this, or asking me. So give me information and let me make the decision as to whether or not I either want to mortgage my house for it. I want to, go and work a second job, working Uber, but give me information so that I can make the best decision and an informed decision on the treatment, on the things that I need to do for my life.
Because is that doctor withholding that information to somebody in the Oprah Gold Coast?
No,
not
at all.
They're offering them the state-of-the-art, best treatment in the world, right?
Yep.
But for somebody in Southside Chicago, what are they saying?
Zip code.
They're not telling you.
They're not telling you. No,
because they assume you're.
They're so absolutely. Again, it goes back to what Dr. Wood said. Your zip code, should not determine, the level of care that you receive. But so often, that's what's happening. So your zip code, the fact that you live on the south side of Chicago, that's going to be what doctors look at and go, oh well, you know what? They may not be able to afford this treatment. That patient may be on Medicare or Medicaid. But if I want to mortgage my house, that's my prerogative. Give me information, but so often that is not happening. And African Americans and minority communities are known to have to receive the harshest chemo treatment.
Right. Yeah. And when you take that globally and you think about other countries, it's sort of the same thing. If there's no access to that drug in that country, that patient's not even told about it.
No.
Right?
No.
Even though they may have a community that raises money for them, like we've seen in Africa, when somebody needs something, the community raises money for them, right? Absolutely. And we've seen other situations where people have gotten in touch with family members and gotten access to that treatment, where they've traveled to another country. And so you say, don't make my decisions for me. It's racist.
It is racist. And you're putting a clock on my life. And that's what it feels. It feels like we are counting down and saying, there's nothing else we can do for you because you can't afford it. And it's like, so I'm not worth you at least giving me the treatment that I need to have because you feel that I can't afford it. But yet we're in one of the most wealthiest countries, but yet we are determining the lives of people, their viability by their ability to pay. And so that's why I advocate for universal health care.
Yeah. And so it really does come down to the one word you and I discussed earlier, which was dignity.
Dignity.
Could you explain how dignity comes into this whole equity discussion?
It plays a role because dignity means that you are acknowledging that I am a whole individual. You are acknowledging my autonomy and my ability to make decisions for myself. But you are also stating that, you know what? You are in control of your personhood. We need to acknowledge that they exist, that they are being seen, and that is one of the most. I didn't feel seen, and I didn't feel like anyone respected me, and I didn't feel like anyone cared about me. But dignity, again, it goes back to that question. It allows an individual to say, you know what, when you ask me dignity questions, that means that you're allowing me to say to you that I'm having, these issues without making me feel, like, okay, you know what, you can't afford this.
Yeah.
Wow.
Yeah.
That's a slap in the face. And that makes you feel like I now understand, and I share a brief history. In the Black community growing up, I remember my grandmother having us dress up before we would go out. And that was because, and I didn't understand it then. And so I grew up making sure that I was, dressed, before I go to the store, before I went to the doctor's office. And that was because she wanted to make sure that they saw us and that they knew that we were dignified and that they gave us respect because of the biased nature by which people look at minorities. And so if we were dressed, you couldn't look down upon me. So when we talk about that dignity, that's what that looks like. That's what that feels like. It feels like when people don't see you, they're looking down on you. When people don't respect what you're saying and what you're doing, they're looking down on you. So that dignity makes you feel like I'm less than. So dignity is very important no matter where you are, here in the US or abroad. That's important. And when we think about what's happening in, low, and I hate to say low to middle income countries, but it is so undignified. It is so disrespectful. It is so
almost criminal.
It is criminal.
Yeah.
It's dehumanizing. And so when we see this, and that's why the work that we're doing is important, because we want to acknowledge that they are seen.
So we are in the process of creating this call to action, and we will invite you, all of the participants in this Congress and all stakeholders who care about colorectal cancer, to join us in this effort. Stay tuned to our website. There's information on our website now in the About section where you can do a drop down and sign up. It talks about call to action, and we will be finalizing this call to action. We've already had our first conversation with the World Health Organization. We will be following up with them shortly about programs that we can work together to tackle colorectal cancer finally in an equitable way, from, as you say, Candace, from rebuilding the system up.
Yes.
And that's exactly what we're going to do. We're going to rebuild the colorectal cancer system so that everyone in the world will have the same access to screenings, to testing once they're diagnosed, and access to treatments, so that no matter where you are in the world, you will have equitable access to colorectal cancer treatment, prevention strategies, and treatment strategies for once you're diagnosed.
Yes.
And that's really what we're all about. We want to make sure that no matter where you live, you have that access. And it's such a pleasure to have you joining us, to make sure and to keep us to our mission, to keep us to our word, to make sure that we follow through with that promise. So stay tuned, everybody that is watching this. There will be a call to action that everybody can join.
Yes.
And I just want to take the last minute or two to once again thank you for all of your hard work in bringing together the best speakers in the world on health equity to help us stick to our commitment to health equity for colon cancer patients all around the world, to make sure that no matter where you live, you have this equitable access.
Yes.
And we champion this now, and we will continue championing it with our partners, with industry, with our members. So I would encourage everybody to go to our website, our brand new website, which was just launched, and check out what we're doing in all of our different programs and in our health equity for sure. And lastly, I want to, of course, thank all of the people that work behind the scenes for the Global Colon Cancer Association.
Yes.
There's more than a dozen people that none of you see in the various rooms running this conference and putting everything together,
Yes.
from logistics to speaker information to getting the recordings. And we have very few hiccups today. So a big thank you to everybody. And of course, that all starts with our president, Nicole. She does everything to keep this organization accountable and running. And big thanks to Nicole for all of her hard work in getting this conference done. So stay in touch with all of us.
Yes.
If you are a nonprofit organization working in the colon cancer space, please join us. Go to our website. You'll find in the membership section, globalcca.org. Thank you, everyone, for attending.
Yes,
Have a great day.
Thank you so much.